Hello, dear all. Thank you for joining the Saudi Anesthesia Standalone Symposium. We will cover today a hot topic of interest in anesthesia by our great speakers in the field of anesthesia. Through our meeting, we will have 2 main talks. We highly encourage you to raise your question throughout the sessions to be discussed in our Q&A time. And at the end of the meeting, we will start now we will start our first talk titled Post-Operative Pulmonary Complication, a Major Challenge in the Patient's Recovery with Prof. Leif Sagar, Executive Vice Chair, Department of Anesthesiology, University of Medical Center, Göttingen, Professor of Anesthesiology, Göttingen in Germany. Prof. Sagar, now the floor is yours.
Okay, thank you very much for the kind invitation and the opportunity to talk a little bit about one of my favorite topics, about post-operative pulmonary complications and the challenges that come with it. Before I get started, I have my disclosure to make that I'm an employee of the University Medical Center here and that we receive various research funds from companies, and that I have also been supported from my research endeavors in those to participate in meetings, and I've listed the companies here, so please keep that in mind as we go through the talk. One of the things that when you look at respiratory complications post-operatively is that you find a very broad range of incidences. So we're not entirely sure how great the incidence really is, and part of that problem comes from a very broad range of how this is defined. The more papers you read on post-operative pulmonary complications, the more various definitions you find. And I gave you a list here on the side where you can see that, some studies include respiratory infection, respiratory, let me see if I can get this going here. There you go. Respiratory infection, respiratory failure, pleural effusion, atelectasis, all these can be included or not part of the definition that this specific study uses. For an example, for respiratory failure, for that specific example, respiratory failure, there became a European respiratory failure. I have a strong echo. I have a strong echo here with my talk. This European group that came together and came up with a comprehensive definition for respiratory failure. But at the same time, respiratory failure. But at the same time, different definitions for the same outcome of respiratory failure. So whenever we talk about studies, I want you to keep in mind that you have to look at the specific definitions that were used before you start comparing studies and comparing results of those studies. Here are an example. This is a multi-center study from the United States. It was a prospective observational study that included 1,200 patients. And if you look at it, they have a definition of pneumonia and found it in 1.8%. They have a definition of pneumothorax, atelectasis. All these were included in the study. And overall, the study concluded as a primary outcome that patients experienced at least one postoperative pulmonary complication in 33% of the cases. That is significant, right? 33% of patients in this study experienced a postoperative pulmonary complication. Huge number. But when you look at the more details, you see that atelectasis and respiratory dysfunction requiring prolonged nasal cannula, those were the two main drivers of this large incidence. And the other outcomes, ARDS, bronchospasm, pleural effusion, they occurred in a much lower incidence. There's also European data out there. This was a very large prospective observational study across 28 European countries. It included 211 hospitals, a total of 22,000 patients that underwent non-cardiac surgery. And if you look at the primary outcome here, they found an incidence of 8%. This is much lower than the US study that I just showed you compared to the 33%. But if you look at their definition, they included respiratory failure, pulmonary infection, pulmonary infiltrates, atelectasis, aspiration, bronchospasm. So these definitions are much harder clinical definitions than an extended period of a nasal cannula with oxygen. So that might be one of the reasons why they found a smaller incidence, but they included more severe major outcomes of pulmonary complications. So if you summarize whatever is out there, you can see that globally we perform more than 230 million major surgeries per year. And somewhere in the range of 1 to 23% of patients following major surgery experience a postoperative pulmonary complication. That makes it more common than cardiac complications after surgery. The most common postoperative pulmonary complication is respiratory failure. And I showed you the large variability in incidence that can occur due to varying definitions, but it also could be the population, practice pattern, and regions that contribute to this variability. If you experience a postoperative pulmonary complication, that's a bad thing. The 30-day mortality is significantly increased. Patients who experience postoperative pulmonary complications have an increased 30-day mortality of somewhere between 40 to 30% versus 0.2 to 3% in patients without this complication. That is the short-term mortality, 30 days after surgery. But also the long-term mortality, 3 months out after surgery, is increased by these complications, 24% versus about 1%. So mortality is significantly increased, but also hospital length of stay is prolonged somewhere around 13 to 17 days in patients that experience PPCs. PPCs also increase cost of care. Obviously, if mortality increases, if cost of care, if prolonged stay, it increases the cost of those complications by about 40% due to pneumonia or respiratory failure. One study looked at postoperative pulmonary complications following GI surgery and demonstrated an increased cost by about $25,000 for these PPCs. So they're common and they have bad outcomes if you experience them. We also do know who is at risk for these complications. It's patients who undergo emergency surgery. It's patients who have prolonged surgeries, complex surgeries. The site of surgery has an influence on PPC. If you're elderly, if your ASA's physical score is above 3, if it's higher, you experience more PPCs. And of course, patients who come into surgery already with certain comorbidities, like COPD, like congestive heart failure, all these patients experience a higher incidence of postoperative pulmonary complications. Other risk factors are smoking and residual neuromuscular block. When you look at these risk factors, I ordered them, but the one I want to focus on is residual neuromuscular block, because compared to the other ones, it's a modifiable risk factor. Emergency surgery means somebody shows up at 2 a.m. at night in your operating room. There's little you can do about it. He's there, you need to take care of him. The site of surgery is determined by the underlying illness. There's nothing you can do about it. He shows up in your OR and you have to take care of his problem. There's nothing to modify in that risk factor. Elderly patients become more and more common in your operating room. But again, they show up, you need to take care of them. You can't modify their age. Residual neuromuscular block compared to that is a modifiable risk factor. It's something we, with our management and our monitoring, can actually do something about. And that's, for the next slides, why I want to focus on it. The consequences of residual neuromuscular block are severe. You have upper airway obstruction. You have a pharyngeal dysfunction. You have an increased risk for aspiration. You have an impaired hypoxic respiratory drive. Hypoxia is more common. It does make the patient more uncomfortable. He feels at unease, and it prolongs his stay in the recovery room. These are the consequences of residual neuromuscular block. And they're clinically relevant. They're not only theoretical risks. This is a list of studies that looked at the clinical relevance of residual neuromuscular blocks. And they found that patients who were extubated with a TOF ratio below 0.9 at extubation, they show a higher incidence of postoperative hypoxic events, and they stay in your recovery room for longer. Patients with a TOF ratio of less than 0.9 on PACU admission stay an average of 80 minutes longer in your recovery room. They have increased patient discomfort. Surgical patients with residual neuromuscular block in PACU experience a 3.5-fold increased risk for postoperative pulmonary complications, what we want to talk about, right? This is directly related. In a study, matched cohort study of nearly 40,000 patients, the use of muscle relaxants were associated with an increased risk for hypoxic events and reintubation. The use of neostigmine in the study was associated with an increased risk for postoperative hypoxic events. Because, right, who gets neostigmine? Neostigmine is given to those who receive muscle relaxants, right? So that relates to the first point. That's why people who receive neostigmine are at a higher risk. And of course, if you reintubate somebody, if you send them to the ICU unexpected postoperatively, they have a 90 times higher risk for in-hospital mortality. So this is a serious problem with high relevance to the patient and to us as caregivers. Unfortunately, the incidence of residual neuromuscular block is still very high. And I brought you 3 studies to demonstrate this. Unfortunately, they did not transfer completely correct, so I got to walk you through the slide and give you some explanation. This was a study conducted in 32 hospitals in China. They looked at 1,500 patients. 70% of them were female, and they monitored the TOF ratio throughout surgery and throughout extubation, wake up, and transfer to the recovery room. But they monitored the TOF ratio blinded to the caregiver. The caregiver could administer muscle relaxant, could administer reversal, and could monitor neuromuscular function at his own discretion and the usual clinical practice. He was free to do whatever he does usually. This was general clinical care in their hospitals. And the investigation was done blinded to the caregivers and recorded. And they found an incidence of residual neuromuscular block. This was here. This didn't transfer correctly, number 1. This is at tracheal extubation. And green means a TOF ratio of greater than 0.9. So this is what you want. You should extubate patients at a TOF ratio or greater than 0.9. But this occurred only in 42% of the patients. 17% of the patients here in yellow have a TOF ratio between 0.8 and 0.9. 11%, this is the light blue, is 0.7 to 0.8 of TOF ratio. 7% have a TOF ratio of 0.6 to 0.7, and an astonishing 22% had a TOF ratio below 0.6 at tracheal extubation. So these were experienced clinicians, free to administer the drugs, free to monitor and guide their clinical care as they see fit. And our judgment influences our decision and led them in 22% of the cases to extubate patients at a TOF ratio below 0.6. So our clinical eye on the patient is very tricky and misleading if we don't objectively measure these patients. This here, number 2, is supposed to be at arrival in the recovery room. And you see that at the arrival in the recovery room, about 55% of the patients had a TOF ratio above 0.9, and a total of 45% of patients still had a TOF ratio below 0.9, and about 23% still below 0.6. So this was about 1,500 patients in 32 hospitals in China. The same study, very similar design, very same study, was also conducted in 8 hospitals in Canada. Very different healthcare system, different clinical practice. Again, they investigated 302 patients with the same study design. And again, for these time points, they looked at tracheal extubation, here number 1 again, and they looked at arrival in recovery room. And again, for these, 36% at extubation had a TOF ratio above 0.9, 37% had a TOF ratio below 0.9, and again, 22%, very similar to the study in China, had a TOF ratio below 0.6. At the recovery room arrival, very similar picture, 56% of the patients, still a TOF ratio below 0.9, where you actually should not be extubated at this TOF ratio, and still a high incidence of patients below 0.6. A third study, just to complete the picture, this was also a multi-center study, very similar design, conducted in 10 hospitals across the United States. Again, different healthcare system, 255 patients, a mean age of 50 years, 70% female, similar to the other studies, a BMI of 32, and a use of neostigmine in 99% of the cases. This was conducted in 2012 and 2013. That was before Sugammadex was available in the United States. 8 academic places and 2 community hospitals that participated. So again, if you look at the columns, overall, this is a summary of 255 patients. You can see that, again, 64% were extubated at a TOF ratio below 0.9. 30% had a TOF ratio below 0.6. This was interesting and additional information because it was conducted at academic and community hospitals. So university hospitals but also smaller community hospitals. Number two, this here shows you the academic hospitals, and this shows you the community hospitals. And it shows you that academic hospitals and community hospitals are very similar in their performance, and in community hospitals, even more so, more patients got extubated at inadequate TOF ratios. So, to summarize this, residual paralysis, residual neuromuscular block is common. And if you don't exactly objectively measure it, it often goes unnoticed. So there's an incidence in a meta-analysis that was performed that found 41% of patients suffer from insufficient muscular recovery. If you calculate that up to the number of surgeries performed, that comes to about 112,000 patients annually who are at a high risk for adverse events that are associated with residual neuromuscular block. Those are alarming high numbers, and the question becomes, what can we do about this? So in my previous life, before I was here in Göttingen, I was part of the multi-center perioperative outcomes group at the University of Michigan in the United States. And the MPOC group there is a collaboration of over 50 hospitals in the United States and a little overseas hospitals as well, but they share their electronic medical record, their perioperative patient information, into one large data set. And this graph shows you a little bit the flow where there is the interaction between patient and provider that generates the information that is entered into clinical systems, into the computer, into a large database. It gets structured and de-identified from patient information and then uploaded to a central coordinating center at the University of Michigan. And over time, there accumulated millions and millions, over 15 million patient records in this database with very highly granular minute-by-minute information, intraoperatively blood pressure, every medication administered, every vital sign, every physiological data recorded, baseline medical information, ICD-9 disease codes, procedure codes that were done, timestamps, lab values, highly granular, very informative data, but it's a very, very large data set with a lot of information. But what we also did was structure this information and make it more helpful and usable. If you think about what we actually did, right? Think about how would you define diabetes? If you want to identify in a data set of 15 million patients, how do you identify diabetics? Do you say everybody who receives insulin, I call a diabetic in my study? Do you go by lab values? Everybody who has an H1C value is called a diabetic. Do you go by everybody who has a ICD-9 code for diabetes? That's what I call diabetic. So you can come up with a lot of combinations or individual definitions of how you would identify a disease state, but what we did is we created phenotypes for every scenario where we say this is our standard definition. So for patient characteristics, for exposure variables, for outcomes, we came up with standardized definitions like little Lego blocks. And whenever you wanted to do a study, you could just pick the Lego block and put those blocks together with standardized definitions and easily use your data. So we use that data to come up with quality metrics to give providers feedback. And two examples I have here for neuromuscular monitoring is that we recorded as a quality metric if a train of 4 was taken during the procedure. And the other one, quality metric, was if a patient received a muscle relaxant, did he receive reversal at the end of the procedure? So we came up with definitions and said, if you received a muscle relaxant, that's the inclusion criteria, atracurium, cisatracurium, pancuronium, those are all the clinicians. And if you don't have an exclusion criteria because you're an ASA 5 or 6 class, or you have cardiac surgery on pump, then you would fall into this calculation. And success would be if you document a reversal that was given before extubation, or if between extubation and the last administration of a muscle relaxant, there's a time frame greater than 3 hours. We said if the last dose of muscle relaxant you received more than 3 hours ago, then you're also safe on your quality metrics. So we calculated all these, and then we came up with individual emails that we provided a feedback to the providers to tell them how they were doing on this. And utilizing this large data set and having that data available provided a unique opportunity for us, because it took a while globally Sugamadex already was available for a number of years. The approval process in the United States took a while. So we could observe the introduction of Sugamadex in this electronic database by having at the beginning, nobody had Sugamadex available. Once it was approved, it showed up in the database, and more patients who were electronically recorded received it. So we used this time frame to conduct a multi-center study to compare Sugamadex and neostigmine for reversal on post-operative pulmonary complications. This study spans a very long time frame from 2014 to 2018, and I'll show you in a second why this was necessary for such a long time frame. So our hypothesis here was that the choice of neuromuscular reversal may be associated with a lower incidence of major pulmonary complications. And we wanted to estimate the incidence of postoperative pulmonary complications in this population and the independent association between the choice of reversal agent and the likelihood of postoperative pulmonary complications. So we included patients from this electronic database. This is an observational study from this database where patients were above the age of 18. They had to undergo general anesthesia with endotracheal intubation. They had to receive a neuromuscular block, either by bolus or by infusion. And they had to reverse either spontaneously with neostigmine or receiving the recommended dose of Sugamadex. Those were the inclusion criteria. We also had a long list of exclusion criteria, and I quickly just want to highlight a few of them. So patients with ASA physical status 5 or 6, we did not exclude. Institutions. So I told you in the beginning, we had 50 institutions contributing data to this electronic database. But as you saw on the initial slide, only 12 hospitals participated in this study. And one of the reasons was that some hospitals very rarely use reversal agents. That was their practice pattern, and they just don't use it that common. So if hospitals in general did not use muscle relaxants, we excluded them from the study because it would bias the study results compared to the other hospitals. Patients who already arrived intubated to the OR or had emergency surgeries, we excluded. Patients who are transported directly to the ICU, they're still intubated, we excluded them. Cardiac surgery, lung or liver transplant surgery, those kind of major cases due to that frequent use and staying intubated, we excluded from the study. Also, we wanted to control the effect of our ventilatory strategy on postoperative pulmonary complications. That's why we excluded patients who were ventilated throughout the procedure with a very high PEEP of above 10 centimeters. So there's a long list of exclusion criteria. What I do want to draw your attention to is the study design that we use. This is, I think, a unique feature, but a little bit complex to understand. So, as I said, there was a time frame before the introduction of Sugammadex that we have patients in the data set, and there's time frame after the introduction. So this is the introduction of Sugammadex into the US market. That's where it became available, and we call that time zero. Typically, when you do a database, a retrospective study, you take patients that received Sugammadex and you compare them to match them to patients who received neostigmine. But the problem, if you do it that way over the same period of time, is that you have biased populations. Patients received Sugammadex for a reason. They were the ones who have very strong, very high BMEs, very obese patients, very high-risk patients. So if you take those patients that received Sugammadex for a specific reason, and then you use the same time frame to match identical patients who received neostigmine, you're not going to find them, because there was a reason why the others received Sugammadex, and there's a problem finding matching patients because you have a biased population. And the trick in this data set is that we could go back in time, the pre-Sugammadex period, where no Sugammadex was available. There was no bias there because neostigmine was the only choice you had at that time. So we went and found our Sugammadex patient population for the study in the post-Sugammadex period. When you introduce a drug for the first time, everybody needs to get familiar. It's restricted use. You have to be careful. There are protocols in place. People are unfamiliar with the effects. So what we did is we looked at, in the data set, when was the first date a specific one institution, for all those 12 institutions, we identified the individual institution's date they used Sugammadex for the first time. Then we added a 6-month period that we called, this was the familiarization period, the getting to know period. This is where they learned how to use it and got familiar with it. And after that 6 months, for that individual hospital, we identified patients who received Sugammadex. Those were the Sugammadex reversed patients that we identified in that period, 6 months after introduction, up to August 31st, 2018. So that is a slightly different time frame for each of the 12 hospitals, depending on the T1 when the 6 months period actually started. And then once we identified these Sugammadex reversed patients, that's when we went back in our data set, back to the pre-Sugammadex period, and matched them 1-to-1 to patients where there was no bias because nothing else was available than neostigmine. So all these patients, even the high-risk ones, even the high obese ones, they received it, and we matched them to neostigmine reversed patients. Now that's how we created the study population, a historical neostigmine reversed data set before the availability and a Sugammadex reversed matched patient population in the post-Sugammadex period to make them more comparable. So this one-on-one match happened on institution ID so that we didn't compare between institution and practice pattern in this case. We one-to-one matched for gender of the patient, for age, ASA status, For BMI category, for the type and the region of the surgical procedure, was it ENT surgery, was it abdominal surgery, and we matched for comorbidities of those patients. The outcome we looked at, the primary outcome of this study, was a composite of postoperative pulmonary complications. By our definition, there was pneumonia, respiratory failure, and other major pulmonary complications as coded with ICD-9 codes in the medical records. For secondary outcomes, we looked separate at the individual coding of pneumonia and respiratory failure. When we did all these calculations before the matching, we had about 90,000 patients in the neostigmine and 30,000 patients in the Sugammadex group. After the matching, this one-to-one match of patients, we ended up with 23,000 patients in the neostigmine group and 23,000 patients in the Sugammadex group. This is the study population that we compared in this analysis. And you see a median age of 59 in those two groups. And as you see, exact matches, 45% roughly were male patients, 55 were roughly female patients. And you can see that, there were 3% ASA1 patient, 40% ASA2 patients, 55% ASA3 patients. So a fairly sick study population with more than half of the patients ASA3 patients. BMI was 28.5% in these patients. So how did they do? This is the result of the primary and secondary outcomes. And you can see in blue patients that received Sugammadex for reversal, and in red patients that received neostigmine for reversal. And we found that 780 patients, so 3.5% of the study population, experienced a pulmonary complication when they received Sugammadex, and 4.8% experienced the complication when they received neostigmine. So there was an odds ratio of about 0.7. So there's about a 30% reduction in complications of Sugammadex versus neostigmine. If you look at the secondary outcomes, it's 1.3% in pneumonia Sugammadex versus 2.2% in neostigmine. It's 0.8% respiratory failure for the Sugammadex group and 1.7% for the respiratory failure group. So all consistent results, all signals show in the same direction, that in the Sugammadex group, there was a significant reduction in PEPC event rates after receiving the reversal. So when you adjusted all these results, then you could see that there's a very consistent reduction where administration of reversal favors Sugammadex, right? This is our primary outcome of pulmonary complication, and it's an odds ratio of 0.7%. And same for pneumonia, it's a 0.53 odds ratio and 0.45 odds ratio for respiratory failure. There's a very clear, strong signal that receiving Sugammadex for reversal is favorable over receiving neostigmine for reversal to reduce postoperative pulmonary complications. Of course, I was very focused here on postoperative pulmonary complication prevention, as I said, with modifiable factors of the residual neuromuscular block. So the point I wanted to make is that you need to consider active neuromuscular blocking management, your management intraoperatively, your monitoring intraoperatively, and your reversal choices that you consider. But there are other factors that you can do to prevent postoperative pulmonary complications as well. There are factors where data supported your choice of general over regional anesthesia. But there are inconsistent results. So there's no general recommendation made because studies are inconsistent. But you can consider your analgesic regime postoperatively. Smoking cessation perioperatively certainly helps. Correction of preoperative anemia. Your intraoperative ventilator management affects postoperative pulmonary complications. Your choice of gastric tube versus non-postoperative support in terms of CPAP, of high flow, of incentive spirometry, those choices can help with the prevention of postoperative pulmonary complications. And also early physiotherapy and mobilization are important factors. So I hope that with this data, I was able to demonstrate to you that postoperative pulmonary complications are occurring in large numbers, that residual neuromuscular block is a significant contributor to this, and that it goes often unnoticed, and that we do have options to actively manage and reduce the incidence of postoperative pulmonary complications. Thank you very much for your attention.
Thank you very much, Prof. Sagar, for this perfect presentation, touching one of the most interesting topics among anesthesiologists. Now we will move to second talk that will discuss deep blood, and if it is does really work. This talk will be presented by Dr. Ibrahim Muhammad, consultant anesthesiologist at Dr. Sulaiman Al Habib Medical Group. Welcome, Dr. Ibrahim, and the floor is yours.
Everyone, working with Al Habib in 7 years, considered one according obesity and in metabolic.
Sorry for this. I think Dr. Ibrahim has a connection problem. He will join us within minutes. And sorry for disturbance.
Hello? Hello? Ahmed, I'm back.
Okay, Dr. Ibrahim, you can go now.
Sorry, everyone, for the interruption of the connection. In the next slide, we can see here this is a map showing the distribution of obesity in adults. Saudi Arabia, as you can see, is one of the countries with the highest rate of obesity. That the laparoscopic bariatric surgeries are growing as well. During the last decades, the number of laparoscopic surgeries increased worldwide. About 7.5 million laparoscopic surgeries are performed annually. Laparoscopic procedures appear to be associated with quicker recovery, shorter duration, and hospital admission, and reduced post-operative pain compared to conventional open surgeries. Put our community of anesthesiologists in a great challenge in giving safe anesthesia to our patients and enhancing the factors which ease the procedure which puts the community of anesthesiologists in a great challenge is in giving safe anesthesia to our patients and enhancing the factors which ease the procedure for the surgeon to guarantee safety of our patients. Our topic today is about deep block, which is one of the most debated topics in anesthesia. And let's start with defining what is deep block. Deep neuromuscular blocking is defined as a train of 4 count of 0 or post-tetanic count of 1 or 2 among adults. While this puts us with another definition, what is moderate neuromuscular block? The moderate neuromuscular block is defined as as we can see, in the train of 4, zero twitch means 100% of receptors are blocked. So in deep block, we need to block 100% of receptors. While, as we said, in the moderate block, it's 1 to 4 twitches, so 75% of blocking of receptors are enough in the moderate block. But in deep block, we need to block at least 100% of the receptors. Neuromuscular blockage, especially deep neuromuscular blockage, can lead to post-operative residual muscle paralysis, which exposes the patient to additional risk of delayed respiratory function and recovery, even in the neuromuscular monitoring. Moderate neuromuscular blockage reversal with neostigmine takes time and remains unpredictable. With high rate of post-operative residual colorization, since the introduction of Sugammadex in 2008, deep or even intense neuromuscular blockage induced by rocuronium can be reversed much more quickly and easy. In 2021, the British Journal of Anesthesia published this interesting article, which says deep neuromuscular block doesn't improve surgical condition in patients receiving sevoflurane anesthesia for laparoscopic renal surgeries. This is a single center, which is Leiden University Medical Center in Netherlands. Post-operative, it's a randomized, double-blind, prospective study in which about 98 patients scheduled for elective renal surgeries who were randomized and received deep or moderate neuromuscular block. Anesthesia was maintained. In surgical condition, scored 15 minutes interval by one of 8 blinded surgeons using 5 points surgical rating scale, which is 1 is poor surgical conditions and 5 is optimal surgical condition. And as you can see here, the mean of the surgical scale is almost equal, 4.8 in the moderate block, and DMD block, it was also about 4.8. And so the study shows no difference between using D block versus moderate block. Here's another article published in 2018 in the Turkish Journal of Anesthesia saying, does deep neuromuscular blockade facilitates laparoscopic surgery? The picture is not clear. Actually, in this the deep block is superior to moderate block or not. Also, recently published meta-analysis compared the effects of low versus standard pressure pneumoperitoneum. We found that 90% of laparoscopic cholecystectomy can be performed under low pressure pneumoperitoneum without any problem. He's speaking about 90% only of patients, and there's another 10%. So there should be a particular care should be taken for the remaining 10% of patients, because this 10% of patients still at risk of surgical interventions. But unfortunately, there is not sufficient also available data about patients with high cardiovascular risk. Furthermore, there is no significant evidence suggesting that administration of low intra-abdominal pressure would reduce post-operative shoulder pain. There is also a very old study. I would like to put it in my presentation. It's an old study since 1996. It's a French study. And in this French study, it suggests that gynecological laparoscopic procedure can be performed even without neuromuscular blocking agents. In that era, they were not speaking about deep block or moderate block. They were speaking about using muscle relaxant or not using muscle relaxant. And there's a time in this study, the authors suggest they can do the gynecological laparoscopic procedure even without muscle relaxants. Also, there's a study coming from Egypt in 2019, and this is a recent study. And this study is on 60 patients. It was a double-blinded randomized study, which is studying the effects of deep block on lung mechanics. And this is new in this study. I cannot find any other study studying especially the lung mechanics. And the exposure of most of the studies were evaluating the deep block or moderate neuromuscular block regarding exposure of field, regarding the quality of field, but they were not testing the lung mechanics. In this study, conducted the deep neuromuscular block in morbid obese patients undergoing laparoscopic bariatric surgeries. And this study was for only patients doing bariatric surgeries. Compared with moderate block, it did not improve the quality of surgical exposure conditions according to the results. And moreover, the blockade affects the intraoperative pulmonary mechanics. As you can see here in the charts, the pulmonary mechanics in the post-operatively in the patients receiving deep block was worse than the patients receiving moderate block. And post-operative pulmonary functions, post-operative pain, and incident post-operative complications. This study also was against the use of deep block. At the end of the study, the author suggests there is no difference between the two groups. Okay, we see a lot of studies which are against the use of deep block, against the use of moderate block. This takes us in another important question: is deep block a safe practice? In this study, which is done in Japan in 2013, it shows the risk of train-of-4 ratio less than 0.9 after tracheal extubation, even after Sugammadex. In 2013, the Sugammadex was about 4 or 5 years introduced into the community, and the studies on Sugammadex was not fair enough at that time. And in that people who use Sugammadex in their practice, they were given Sugammadex without neuromuscular monitoring. It says that while using Sugammadex, the train-of-4 ratio remains high, which is less than 0.9%, in 9.4% of cases. And it shows the importance of neuromuscular monitoring, even with Sugammadex is used for antagonism of rocuronium induced in neuromuscular block. Also in this study is more surgical study, and it's discussing the factor as associated with conversion from laparoscopic to open colectomies. Actually, I was expecting one of these factors is a neuromuscular blocking agent used, or depth of neuromuscular blocking, but the author here put the age, body mass index, ASA classification, presence of diabetes, smoking, chronic obstructive pulmonary, stroke, weight loss, chemotherapy. He think only these factors are the factors which can convert the laparoscopic colectomies to open colectomies, and no one mention here to neuromuscular blocking agent or depth of neuromuscular blocking agent and the anesthesia served to this patient. All the studies we illustrated before was the studies against deep neuromuscular blocking. The upcoming studies we are going to illustrate is the studies within the deep neuromuscular block. And we, as I said, we illustrated some articles shows deep block has no benefits against moderate block. We are going to illustrate strong articles now, which has another opinion, starting with this study, which is the effect of variations in depth of neuromuscular block on rating the surgical condition by surgeon and anesthesiologist in patient undergoing laparoscopic, renal, or prostatic surgery. This study actually is a prospective randomized blinded parallel group and controlled trial. In this study, they 24 patients, each 12 patients. In group 1, they used deep block with rocuronium and reversed it with Sugammadex. And in group 2, they used atracurium, moderate block, and reversed it with neostigmine. Actually, I find this point is a weakness point in this study, because in both groups, he didn't use the same neuromuscular blocking agent. As I said, in group 1, he used rocuronium, and in group 2, he used atracurium and mivacurium. And reversal in first group was using Sugammadex, and reversal in second group was using neostigmine. And I consider this a weakness point in this study. But anyway, In these studies, they used the surgical rating scale, and there is something unique about this study. In this study, the unique thing is that they used only one surgeon. Compared with the studies we illustrated before, the study we illustrated before, they used 8 surgeons in evaluating the fields and the efficacy. Surgeon performed all the cases, and by using only one surgeon in the study, it reduced the subject variability in a scoring system, which is very important. The single surgeon was selected to perform the procedure, as I said, and he scored the surgical conditions. And as you can see here in the results of the study, it shows about 70% of the patients receiving deep block was in optimal condition, according to this surgeon. But only 10% of the patients underwent to moderate block were in optimal conditions. Also in moderate block, 20% were in good conditions, and 55% or the majority of the moderate block patients were only acceptable conditions, and in poor conditions was only 10%. In patients received deep block, as you see, optimal conditions for 70% of the patients, which is, we convert 70% to 10%, there is a great difference. And in good conditions, about 20%. In acceptable conditions, in 10%, and we cannot find any patients on poor conditions or extremely conditions. As I said, the majority of the patients were in deep block, were in optimal conditions. In 2018, the Cochrane Library has published this protocol, which is, I think, is the best analysis of trials which has been introduced in this subject. Deep neuromuscular block in adults undergoing in abdominal laparoscopy procedure protocols. These protocols actually is to assess benefits and harms of deep neuromuscular blockage on early operative recovery in adults undergoing laparoscopic intraperitoneal procedures. And I think this protocol was best guidance. Other researches and other meta-analysis, which we will illustrate later. In 2014, the European Journal of Anesthesia published this interesting study, which is done on 100 patients. Deep neuromuscular block improves the surgical conditions during laparoscopic hysterectomy. Actually, as we can see, the results of the study says there is a significant improvement in surgical field scores and made it possible to completely prevent the unacceptable surgical conditions. This study also, I stopped in this study. Actually, this study was not against and not within deep block. But what stopped me in important rule of anesthesiologists to reduce perioperative stress response. And stress, as we know, is a catabolic reaction in response to surgery and trauma. One of the studies published in the scientific reports has compared the stress response after deep and moderate neuromuscular block. Actually, the study by the end and conclusion says no difference in the two groups. The deep neuromuscular block and the moderate neuromuscular block in relation to the inflammatory cytokines. Also, the European Journal of Anesthesia has published in 2019 a randomized controlled trial. And this trial was done on 65 patients undergoing on bypass surgery. The study found that the significant improvement in of surgical conditions. As moderate block, if you can see here, moderate block, there is 4 out of 31 patients shows improvement in the deep block, which is, and in the deep block there is 29 out of 34 shows improvement. And the condition of the study says switching from moderate to deep block improves the surgical condition, and poor surgical conditions were associated with higher incidence of surgical complications. So in these studies, they strongly recommend the use of deep block against the use of moderate block. In Boston Anesthesiologist, which was held in 2017, Christian Martin and there's although the studies shown a high dose of recuronium, they improve surgical conditions in certain procedures. There is little information on the effect of deep neuromuscular blocking outcome, especially the readmission within 30 days. In this meeting, they recommended that using of deep neuromuscular blocking agent, which will decrease the complications, and it will lead to decreasing the readmissions of patients, and of course it will decrease the cost, because readmission means increasing the cost, and decreasing the risk of readmission meaning decreasing the cost of the procedures. I was honored in 2021 to be one of the editorial board of Current Views in Anesthesiology, and we had was a unique topic which enriches the Current Views magazine. It was a systemic review. It was a systemic review and meta-analysis of randomized controlled trials. And in this paper, in this study, it's running according to the quality standards recommended by Cochrane Handbook for Systemic Reviews, which we mentioned before. So it was based on this Cochrane protocol. The trials which was chosen, they chose 15 trials. And these 15 trials coming from many sources. It's coming from US, from Spain, Netherlands, Japan, Belgium, France, Denmark. And in these trials, they choose the trials which compared the deep block and the moderate blocks. And they excluded any other trials which compares between deep block and no block or shallow blocks. They focused on only the study, the list of the studies used, and all the list of these studies was comparing between the deep block and moderate block. In this study, in this systemic review, it includes any impact on the surgery itself, like post-operative pain, post-operative nausea and vomiting, recovery room stay, hospital stay, And according to this outcome, the conclusion of this study that the use of deep neuromuscular block may improve the patient and physician surgical experience. And by improving certain patient outcomes, such as post-operative pain and improved surgical ratings, compared with moderate neuromuscular blocking. However, to avoid under neuromuscular monitoring, and the 3:4 ratio should be more. To summarize this, as we said, the deep neuromuscular blocking is a safe practice with rocuronium and sugammadex. But in one condition, we have to use a neuromuscular monitoring because, as we mentioned in one of the studies, if we use deep block and we use even if we use sugammadex without neuromuscular monitoring, there is a high risk up to 9.3% of recurralization and of TO-off ratio less than 0.9. So neuromuscular monitoring is very essential to use deep block. Also, the deep neuromuscular blocking may facilitate the use of reduced insufflation pressure with compromising surgical field of vision. A lot of studies speaking about the relation between with reducing post-operative pain. Also, a deep neuromuscular blockade was associated with reduction of post-operative pain score in the post-operative anesthesia care unit compared with moderate neuromuscular block. The topic until now is still with big debate and need further researches. But as I said, my hospital, in our hospital, we are doing a lot of bariatric cases every day. And we have a very big list of bariatric cases. And according to my own experience, when we used a deep block, not all surgeons, it's very difficult to satisfy surgeons. And not all surgeons you can satisfy very easily. And there's in worldwide there is some surgeons is frequently in OR, and they are telling the doctors, the patient is tight, please give us more muscle relaxant. And when I started to use deep block in my practice, I noticed that this type of surgeons who are usually requesting muscle relaxation, the requests are dramatically decreased, and the request of neuromuscular blocking agent during the procedure decrease. Actually, when you make the surgeon happy with his field, happy with good view during his procedure, that time you guarantee that the surgeon can do his job very well, and accordingly that you guarantee the safety of the patient and a good outcome for the procedure, less recovery room stay, less hospital stay, and of course impact on either the patient or the hospital or the health system. Thank you very much, everybody, for listening to the topic, and we can go for the question.
Thank you a lot, Dr. Ibrahim, for this great presentation. Now we will start our Q&A with the raised question. First question to Prof. Zagar. Do you see all outcome of Sugammadex deserve the cost of the Sugammadex, Prof. Sagar?
So that's an important question, right? The cost of Sugammadex is significant compared to the other medications. So especially in a constrained environment, you have to make good choices of where to use and when to use it. So many institutions, on my experience, how they introduced it in the United States, many institutions came up with protocols where they identified risk populations, circumstances, specific procedures, and said, this is where we feel the risk is the highest, and this is where we should use it. And on the other cases, we probably can manage them well enough and not use expensive options. I find it a little bit tricky to go by the outcomes because you don't know what that patient is going to experience, right? You first make your determination in the OR. I'm going to reverse the patient. I'm going to extubate him. And then he's experiencing a complication. But rarely at the time of the extubation, you know if he's going to develop pneumonia, if he's going to develop an atelectasis, if he's going to require reintubation. So choosing based on the outcome is very tricky. You try to identify patients who are at high risk, morbidly obese patients, very long surgery requiring deep relaxation, elderly patients, hypothermic patients, patients with severe COPD and risky procedures. So I would rather go by high-risk populations, identify those, and in a setting of limited resources, of constraints, those I would focus on first, and then I would say the other ones I try to manage in my best possible way as well, but probably choose neostigmine as a reversal if I can. So there are other things as well, right? We're talking a lot about the choice of reversal agent, but I do want to make the point that, my colleague made here. Monitoring is the first thing where we should start. We should routinely monitor every patient who receives multiple doses of muscle relaxant during surgery. That's the first thing. And don't monitor just twitches. You do need to make quantitative monitoring with a TOF ratio. Only the TOF ratio will give you the guidance you need. And based on that, then you can make an informed decision. Sorry for the long answer.
Thank you, Prof. Another question for you, Prof. How to convince, just 1 minute, the right doses of Sugammadex as we never use TOF watch?
Right. So, as I said, I strongly say the first step is good monitoring of the patient. So if you use repetitive doses, and especially if you go for deep block or long procedures, the first step is do a good monitoring of the patient. The RECITE studies that I showed you clearly demonstrate that our clinical judgment is very poor. You cannot rely on your clinical judgment to say, I think this patient is okay, I think this patient is not. All those caregivers in those 3 studies thought it's okay to extubate the patient. They were good physicians. They're not doing that. That's what they do every day, right? And it shows you, don't rely on your judgment. You've got to do the measurement. And how to convince hospitals. So the question was the dosing. So,
yes,
right, if you don't measure, it's hard to determine, right? The correct dosing is if you have more than 2 twitches, you should use 2 milligrams per kilogram. If you have 1 or 2 twitches, you should use 4 milligrams per kilogram body weight. So that's the correct dosage. But if you don't measure twitches, you don't know where you are. And don't expect a drug to work if you underdose it, right? So that's unfair to the drug to say, you know, I'm not sure how much I should use. I'll go on the lower end to save money. And then you're surprised if it doesn't work, like all the studies demonstrate. So the correct way is measure where you are and then use accordingly to what your results are.
Thank you, Prof. Dr. Ibrahim, this question for you. How to convince surgeon to perform under low intra-abdominal pressure?
Actually, if the field and the working space is good under low insufflation pressure, I don't think the surgeon will mind to reduce the insufflation pressure, because the surgeons, they know, like us very well, the impact of high insufflation pressure, and what they need is to do their job. They need a good field of view, they need a good space to work, they want to avoid any complications during the surgery, and on the same hand, they don't want high insufflation pressure. If you give the surgeon good fields, good view, good access to his surgery, and you ask him to decrease the pressure, he will never mind to decrease the pressure whenever he has a good block. And according to the studies, we see the D block is best choice for getting a good field and good access of the surgeon to do his job with the patient.
Thank you, Doctor. Prof. Sagar, what is the most common post-operative pulmonary complication in the pediatric field?
Interesting question, because there are far less studies in pediatrics than there are in adult patients, right? But the pediatric studies suffer from the same problems of what definitions do you use, right? So the most common respiratory problems in pediatrics: laryngospasm, bronchospasm, hypoxia. Those are the typical ones that you experience with pediatric patients. But of course, a bronchospasm, laryngospasm can easily be caused by irritation when you remove the tube and they're just not there yet. So that does not necessarily have to do with residual neuromuscular blocks. So some studies include them, some studies exclude them. So the most common ones are certainly laryngospasm, hypoxic events, those kind of things. But in pediatric patients, the etiology can be different.
Thank you, Prof. Dr. Ibrahim, question. We were taught intubation or maintenance doses for neuromuscular blocking. So how can we reach this moderate versus deep plan of block doses, or it is just monitoring approach, not dosing regimen?
Okay, as Prof said a while ago, it's a matter of monitoring. If the patient has a good neuromuscular monitoring, I think you can reach the dose you need to block the patient, you reach the deep block you need. Clinical judgment is not, for some anesthesiologists, they depend mostly on the clinical judgment and they are not use neuromuscular monitoring, but neuromuscular monitoring is very essential to maintain the deep block and to reverse also from the deep block for the safety of the patient.
Thank you, Dr. Ibrahim. Prof. Sagar, is sugammadex has less side effect as compared to neostigmine?
Sugammadex does have side effects as well, right? Bradycardia, anaphylactic reactions. There are side effects described as well. I would say that since neostigmine is always given in combination with glycopyrrolate or atropine together, I would say that I can see more side effects and more other unexpected effects with neostigmine and glycopyrrolate or atropine combination than I do see with Sugammadex as a reversal agent. So there are side effects, right? But I think they're fewer and they're probably not as severe. There are severe side effects, but they're very rare.
Thank you, Prof. Dr. Ibrahim, how long do you recommend keeping in recovery patients who have undergone a deep block?
If the patient is fully reversed from the neuromuscular agent, and if you have like any other patient having anesthesia, even without neuromuscular blocking agent. So if you shift the patient from your OR to recovery, fully reversed, there will be no effect on the recovery room time. And as we said before, the monitoring is essential because of this. You have to guarantee that the patient in recovery will not have some remaining colorization, will not have some respiratory depression, any respiratory complication or pulmonary complications in recovery. So if you are going to intend to do deep block, use a neuromuscular monitoring. And if the patient is fully reversed, you can extubate the patient, you can safely put the patient in recovery without any fear, and the patient can stay in recovery rooms normal time, which is like the patient who didn't even receive neuromuscular blocking during his procedure.
Thank you, Doctor. Prof. Sagar, can we use Sugammadex without TOF monitoring?
So, as I said before, I strongly advocate using monitoring, right? You would not give a vasopressor without measuring the blood pressure first, right? You first measure the blood pressure, you know where you are, and then you give a medication to bump it up or bump it low. So similar applies to muscle relaxation. You first measure, and then you apply your medication, right? You can, if for example, if you don't have a TOF watch clinically, if you don't have it available and you need to reverse the patient, yeah, you can give it. To be safe, you probably give large doses of Sugammadex to make sure that you reverse whatever you have and not end up in a residual, because you don't want to underdose it. But that becomes very costly. If you always use the maximum dose because you don't know where you are, that probably becomes way more expensive than buying a couple of monitors.
Thank you, Prof. The coming question for you, both of you, Dr. Ibrahim and Prof. Sagar, can you share the outcome of using Predion in your hospital?
Start with the Prof.
Start, Prof.
So I 2 years ago I moved here to Germany, which is a very different healthcare system than the United States. So in the United States, after the introduction of Sugammadex, it was very rapidly growing in its usage, and it was very interesting to see, because as it became more and more available, it got used more and more. But at the same time, it was not just only becoming a higher percentage of using Sugammadex, You could also see how more and more providers switched to rocuronium as their muscle relaxant, because they knew that they wanted to reverse the patient at the end with Sugammadex, so they used rocuronium during the case. And you could also see that, they became a little bit less concerned with dosing rocuronium, because they felt that, it's whatever we give, we can safely reverse at the end. So that was a very interesting trend to see. And from the initial restrictions, it very quickly broadened to a more common use. That is very different here in Germany. The healthcare system in Germany has much tighter financial constraints, and there's a much closer look on your medical practice and a focus on using your resources diligently. So in my current hospital, we have very clear policies. We have Sugammadex available, but our regime of using muscle relaxant is more restrictive. We monitor very closely with the TOF ratio, and only for high-risk patients, we utilize Sugammadex. Looking at an individual hospital, if you look at the number of postoperative pulmonary complications, those numbers speak strongly because of the large sample sizes, right? 40,000 patients in the study. If you look at individual hospitals, numbers are too far and few to make a meaningful comment. So our own postoperative pulmonary complications are not very representative of, compared to when you do a multi-center study.
Dr. Ibrahim? Dr. Ibrahim?
Yes. Can you hear me now? Sorry, the connection was interrupted. Okay.
Yes.
According to our experience in our hospital, my hospital is a private hospital, which they count the expenses real by real, and when you request any new drug, the pharmacy board in our hospital has to be well convinced that the outcome of using this drug will reduce the cost. Actually, I used to convince my hospital's pharmacy board, I used the study about the cost. And the study was... Can you hear me well now?
Yes, but the voice is interrupted,
okay.
I think, with connection.
It says now connection is good. Okay. What I want to say is that to convince the pharmacy board in our hospital, I used a study which was done in King Faisal Research Center. This study was done maybe 3 or 4 years ago. And this was measuring the cost effectiveness of using Sugammadex. And in this study, they count everything. They count the OR time, they count recovery time, they count the hospital stay, they count the post-operative complications. And accordingly, when they compared the cost, the study was to comparing the costs. Is Sugammadex the result of the study showing a very big difference in the cost when we use neostigmine compared to Sugammadex. And according to this study, our pharmacy board approved using Sugammadex in our OR. In the beginning, our staff members, they were afraid about using Sugammadex because, Sugammadex was a bright new drug for them, and there is some mentions about bradycardia and following giving Sugammadex, but practicing using Sugammadex in our cases now, I can say most of our cases, especially bariatric cases, are reversed with Sugammadex, because most of us, they are using a lot of muscle relaxant. They are using, most of us, you can say, something near to deep block with our cases. So
the voice, Dr. Ibrahim.
This fast turnover. And now most of our staff, they are using Sugammadex drug. Bradycardia, according to my experience, yes, we can see some bradycardia, especially in patients with a baseline heart rate during recovery low. Yani if your patient heart rate 50, 45, 50. At that time, you can be afraid from bradycardia induced from Sugammadex. So in my practice, what I'm doing, if the heart rate of the patient is low, I give Sugammadex to the patient, and on my other hand, I'm holding atropine. If heart rate comes down or something, the atropine is ready in my hand. But I'm not giving atropine as a routine drug with Sugammadex. And bradycardia, we can see this bradycardia.
Thank you, Dr. Ibrahim. Dr. Prof. Sagar, last question. According to the use of muscle relaxant as infusion, especially Vacronium, is there incidence of activation of Guillain-Barré syndrome?
That is not necessary. That is not my area of expertise with the Vacronium, because we very rarely use Vacronium. I think there are some reports about hypersensitivity, hyposensitivity, and Vacronium in patients with Guillain-Barré syndrome, but I'm unaware of any data that talks about infusion of Vacronium. That is something we very rarely do. We pretty much single dose and bolus muscle relaxants. It's very rare that we use continuous infusions. So I don't have any data to answer that question. Sorry.
Dr. Ibrahim, do you have any data about this question?
Actually, it's outside our area of experience. Also, most of our area experience is on bariatric surgery. So I'm very happy to answer any question regarding this area.
At the end, thank you, Prof. Sagar. Thank you, Dr. Ibrahim, for your informative presentation that touching the field of anesthesia. I hope everyone will get learned from today's presentation. And just to inform the audience that this meeting is accredited by CME for CME hours. Thank you again, Dr. Ibrahim, and thank you, Prof. Sagar.
Thank you very much.
I hope to see you soon in coming events. Thank you.
Inshallah. Thank you very much.
Bye.
Bye-bye.